coronary syndrome and treatment. It talks about the drug treatments in there, but acute coronary syndrome and treatment. We talked about the response to injury theory, the ROI, or the response to injury, RTI, response to injury theory of atherosclerotic formation. We talked about the really the biggest new thing here was the different risk factors, modifiable versus non-modifiable, those potentially strange ones, unknowns, you know, the inflammation, the markers. So those are actually the real new stuff. So I feel more confident utilizing, since I was gone last week, utilizing this section to be an open test because we've already reviewed it. This is more of a review exam anyways. And that allows us to plow ahead and talk about the heart failure and valve disease and things like that is what will come up next. In our afternoon discussion, we're going to pause on the EP discussion, and we're going to go back and finish what we missed last week. And also just finish up this section on acute coronary, of ACLS. And remember, all we're doing here is just learning the algorithms, learning how we respond to, we've already talked about the different rhythms. What we're talking about now in that class is how do we respond to different rhythms if the patient is hemodynamically unstable? How are we going to respond and intervene? There are some videos we'll talk about this afternoon. I hope you watch those videos. I know there's a lot of them, but he does a very good job. Our ACLS instructor who teaches and will certify you in ACLS in the summer is the one who sent me those videos. He said these are probably the best ACLS videos that actually goes through and explain, not just tells you the algorithm, it goes through and explains the algorithm and why we do things and what the purpose is. He said in a simple way, in a very simple, some of them are 20 minutes, I know, but in a simple, short period of time compared to what other websites do or other videos do. He said that it's what he tells students to go to. So I shared a lot of those with you, and we'll go and talk about those in that. But today, what we're going to be talking about in invasive 2 is we're going to start talking about heart failure. So we talked about acute coronary syndrome, heart attacks, #1 killer of people in the United States, in the world actually. Today we're going to be talking about heart failure. And we jump a couple of chapters. So we go from chapter, I believe, 4? No, chapter 6 or 7, and we're going to jump valvular heart disease, and we're going to go to chapter 9 and 10, which is heart failure and cardiomyopathies. And we start with heart failure because we hear this term a lot, heart failure. We want an understanding of what heart failure really is. What are we talking about when we explain heart failures and when we say that the patient is in heart failure? Different types of heart failure. But in reality, as I said before, we're really going to focus on treatments. How are we responding and possibly treating these patients in heart failure? What can we do to improve outcomes in heart failure? So that's what chapter 9 is about. And then next week we'll be talking about chapter 10, the cardiomyopathies, or 3 different cardiomyopathies that we'll be talking about as well. So, but today we are talking about heart failure. And heart failure all goes back to a very simplistic set of theories that we have already discussed in physiology. So yes, physiology rears its ugly head again. Okay, so heart failure gets a little confusing here. I'm going to explain it this way, and we'll get it more into the depths of this later. Heart failure is a decrease in cardiac output, or in some cases, a patient can actually maintain a normal cardiac output, but in order to maintain a normal cardiac output, our heart has issues. So it's a we can have heart failure where the patient has a normal cardiac output, at least for a period of time, but there's still cardiac issues going on that make this problematic. the heart actually starts to sacrifice things in order to maintain cardiac output. There are 4 things that can affect your risk of entering into cardiac output. So these 4 factors I want to be specific. These are 4 factors of the heart that affect and can lead to heart failure. So heart failure is a interaction between these 4 factors. It's when one of these 4 factors is out of range, and it can cause the heart not to be able to maintain a normal cardiac output. So the factors that can be out of range are preload, afterload, contractility, and compliance. Now, we've discussed these factors already. But just to remember, this is in your textbook. This is a quick review of those factors. So preload is the wall tension at the end of diastole. In clinical terms, it's the stretch of the ventricular fibers before contraction that is determined by or approximated by the end diastolic volume or end diastolic pressure. Remember, what preload is the volume load of the ventricle right before contraction. Remember, the heart doesn't stretch because it wants to. The heart is forced to stretch. And that tension created by the stretch is your preload. Okay? So remember, we talked about the length tension curve. When the ventricle fills, the muscles are stretched. That stretch creates a tension or a force, and that force is preload. How do we determine what the preload is? Well, the preload is determined by the end diastolic volume, because the more volume, the more stretch we have. And that volume in the heart is reflected in the pressures that we record. Remember, volume equals pressure. So as the volume inside my ventricle increases, the pressure will also increase. The higher the pressure, the more volume, the more significant the stretch in the resting muscle tissue, the more significant the preload. Does that make sense so far? Quick reference to that. Afterload is the ventricular wall tension during contraction. It is referred to as the force that must be overcome for the ventricle to eject its contents. So it's not just to open up the valve, but to open up the valve and eject all of its blood, or the maximum amount of blood is the afterload. And afterload is, of course, directly related to the arterial resistance. Not the arterial, but arteriole, the arteriolar resistance, the smallest vessel. Contractility and stroke volume are, and ejection fraction are all outcomes of these. So if my preload, afterload, compliance, or contractility are out of place, stroke volume, ejection fraction, cardiac output will be affected. Okay, so they're in here, but these are affected by these other 4 states. Contractility is the strength of contraction. Now the strength of contraction can change, and we talked about that with the length tension curve. We talked about the fact that with the length tension curve, what we can do is we can create a situation, especially by the use of norepinephrine, that allows the ventricles to contract harder and stronger than they usually do. Okay? So we can alter contractility by the neurohormone response. More calcium gates are open, norepinephrine forces the cell to open up more calcium gates. More calcium gates that are open, the stronger that cell and the longer that cell will maintain its contractile state. And then compliance is something we haven't really talked about in regards to the ventricle, but the ventricle also has to have a compliance to it. The ventricle has to allow itself to fill. Up until this point, we have said, well, the ventricle fills passively primarily, but we haven't talked about the compliance of the ventricle. The ventricle has to have a give to it. The cell tissues, the cardiac myocyte has to be able to stretch. It has to have this layer of compliance to it that it will allow it to stretch effectively without providing much resistance. The reason it has to do this is 80 to 90% of my ventricular volume is passively filled, which means there is no force created by the heart to cause the blood to go into the ventricle. The blood just naturally flows into the ventricle from the atria. To allow that, the muscle cells have to have a compliancy to it so it won't resist that blood flow. So as that blood flow is flowing into the ventricle passively, that cardiac myocyte has to have a level of compliance that will allow it to stretch without offering too much resistance. Because if the cardiac myocyte doesn't stretch easily, it'll be harder for that blood to passively enter into the ventricle because the chamber won't be getting bigger quick enough. And we'll have a resistance, so passive filling doesn't work. So if the ventricular muscle tissue doesn't have adequate compliance to it, the ventricle won't fill as well passively, and we end up in a problem. So these four factors, preload, afterload, contractility, and compliance, will affect these three outcomes. Okay, so we have the factors affecting three outcomes. And the three outcomes that we affect are stroke volume, cardiac output, and ejection fraction. Stroke volume is the amount of blood ejected per beat. And if my preload isn't high enough, what happens to the amount of volume I can eject? It's less. If my afterload is too high, what happens to the amount of volume that I can eject? It's less. If my compliance is too low, what happens to the amount of volume I can get into my ventricle? It is less. If my contractility is too low, what happens to the ability of my heart to squeeze? Less. All of those things will cause my stroke volume to decrease. Now my heart will try to manipulate that by doing what? So any decrease in these four factors will be compensated for by what mechanism? Stroke volume times heart rate equals cardiac output. So if my stroke volume falls, I could still maintain a normal cardiac output. Okay? Cardiac output is the stroke volume times heart rate. And so if my stroke volume falls because of these three factors, so these three factors really affect, these four factors really affect stroke volume. If stroke volume falls though, we can still maintain a normal cardiac output. That is still a possibility, but that's usually compensated for by heart rate. And then ejection fraction is the real key here. Ejection fraction is stroke volume divided by end-diastolic volume. We've already talked about that in physiology. Normal range is 55 to 75. We technically say anybody over 50 is quote unquote normal, at least through our LV gram. Is the LV gram the most accurate way to determine any of this? Not really. It gives us a good estimate. But the normal values are really 55 to 75% is considered normal cardiac output. So when we talk about heart failure, one of these four factors, compliance, contractility, afterload, or preload, are messed up. And because those four factors of the heart are messed up, it's going to have an effect on my stroke volume and my cardiac output. Excuse me, first my stroke volume and my ejection fraction. If one of these four factors are messed up, my stroke volume is not going to be as good, and my ejection fraction also will be affected. However, it doesn't mean my cardiac output will be negatively affected, because my cardiac output can be compensated for by a change in heart rate. So that's why when we say, what is heart failure? We say heart failure is go back to this, heart failure is a decrease in cardiac output that is not able to maintain normal function, or cardiac output is maintained despite the cardiac issues. Okay, so we have identified issues with one of these four factors, preload, afterload, compliance, or contractility, but despite those four factors being there, the patient still is able to maintain cardiac output, but they could still be considered in failure. So we're going to go to this quick. There we go. Okay. So this is the PowerPoint that's in the module. So So what is heart failure? If we were going to really define it, it's the state in which the cardiac function fails to pump blood at a volume commensurate with venous return to meet metabolic demands. Okay, what does this mean? It means equal with or the same as venous return to meet metabolic demands. So in other words, heart failure is nothing more than the fact that the heart's not pumping enough blood out to meet metabolic demands, despite the fact that venous return is normal. Okay, so that's what this is saying. Commensurate means is equal. It's not equaling venous return. My venous return is normal. My venous return is coming back. But remember we talked about venous return controlling cardiac output in the normal physiology? Well, in this patient who has heart failure, the venous return, there's nothing wrong with the venous system. They're getting enough blood back to the heart, or they have the ability to get enough blood back to the heart. But the heart itself is incapable of pumping out enough blood to meet my metabolic demand. So it's not capable of maintaining a cardiac output to meet my body's demands. So this is not a venous return problem. The patient's not dehydrated. The patient has no issues with volume. This is a problem with the heart specifically. So what happens is there's an inadequate flow forward, and we also have a backup into the capillary beds. Okay. So what does this mean? Well, this means my heart can't push blood forward adequately to meet my metabolic needs. However, since venous return is normal, my forward output is decreased, but since venous return is normal, that blood that is failing to be ejected out each beat is backing up. Since my heart is failing, that blood that can't get into my heart is backing up into the capillary beds. And we get this thing called edema. What is edema? Swelling, that's right. Edema is the swelling of your tissues. So we'll talk about this in a second. The ACS talked about this a little bit. We'll talk a little bit about it more here. When you have left heart failure, I can't get enough blood out to my systemic system to meet my needs. And so I'm going to have a series of symptoms and signs that we'll talk about here in a second that indicate you have left heart failure. But patients don't really complain about that necessarily. Patients complain about the backup, and that's why we call it congestive heart failure. What does it mean to be congested? Too much stuff. Too much stuff is backed up, right? Mm-hmm. So, for example, if you have sinus congestion, what has happened?
You're not able to breathe.
Yeah, but what's up? Your sinuses are filled up. They can't drain out, right? They're not draining properly. My sinuses are all compacted. They're just, they're swollen. Okay. So when we say congestion, we mean that fluid is backing up. Fluid is, or whatever it is not flowing and not eliminating as well. And so most patients don't complain necessarily about the failure of not meeting my metabolic needs. That's not what we notice right away most of the time. Most of the time we notice the symptoms associated with congestion. When your left heart fails, your lungs get congested. When your right heart fails, what gets congested? Yeah, that's right, the lower limbs get congested, or that your arms and legs get congested. Okay? Most people complain about the failure of congestion rather than the failure of the forward flow, which is oftentimes why we refer to this as congestive heart failure. You're in heart. Congestive heart failure is heart failure that is starting to build up edema. So heart failure just means your heart can't push out, is inadequate in pushing out sufficient amount of blood to meet your body's needs, or in order to do so, blood has to back up and become edemic, or your tissues have to become edemic. So congestive heart failure is the heart failure when it begins that edemic process. We say that you are now congested, you are now backed up, you're now failing backwards. And that'll come up a little bit more here in just a second, because you'll hear me refer to this thing called forward failure and backward failure. And we utilize those terms a lot in heart failure. We used to differentiate heart failures if it's forward or backwards until we realized they're interconnected. You can't do that. But we'll talk about forward and backward failure here. But forward failure is primary what is happening with heart failure. Your heart's not pumping enough blood out to meet the body's needs. And we'll talk about what backwards failure and congestive failure means. So congestive heart failure is connected with heart failure. It can be left or right ventricle in nature.
You said that was left side, right? Congestive?
Both. It's either one. Congestive heart failure is when the blood starts to back up. So it can be, you can have right side congestive heart failure or left side congestive heart failure, or both. You can have left or right heart failure. Heart failure does not necessarily mean that both sides of the heart are affected equally. You can have one side of the heart that just says, I'm not working as well anymore, and the other side of the heart be normal and be able to function properly. So you can have single-sided heart failure. However, if you go into left heart failure, eventually you will go into right heart failure. Okay? So if you go into right heart failure, the only thing that you will have problematic is problems with the right heart. You will have a failure of the right side. If you go into left heart failure, eventually what you will have is you will have a failure of both sides. And you say to yourself, what in the world is he talking about? So, draw my little heart here. I draw my vena cava. Draw my aorta. Draw my pulmonary artery, and I'm going to draw my pulmonary veins. And my lungs. My lungs, of course, drain. Back into my left atrium. Okay. So, what this is basically saying, what that last statement was, is that I can have my right heart fail and my left ventricle could still be normal. No problem. Okay? I can have my left side fail and my right ventricle start off fairly normal, no problem. The problem is with my left-sided failure. If my left side is failing, what happens to the volume that it maintains after each ejection? If I have left-sided heart failure, what happens to the volume that's left over after it squeezes? It's higher. It can't get the same amount of blood out. That's what heart failure is. I can't circulate blood effectively anymore. So after I eject blood out, I have a lot more blood left over than I normally would have. So then that valve, the AV valve opens, and what should happen naturally to the blood in my atria? What should it naturally do? It should naturally flow into my ventricle. However, the amount of passive filling that can enter my ventricle is going to be dependent on how empty my ventricle was to begin with. If my ventricle was still very full after it contracted, will it allow more blood in from the atria? No. So the atria then has to either work harder to squeeze that blood, and what do we know about the atria? Is it a squeezing? Is it a contractile chamber? No, it's going to fail pretty miserably. So the atria says, well, I have two choices. I can either force more blood into the ventricle, which I'm not designed to do, or I can store more blood, which I am designed to do, but I only can stretch so much. So after the atria is maximally stretched, what happens to the blood returning from the lungs? The blood returning from the lungs, since the atria aren't emptying as well, what happens to the amount of blood returning from the lungs?
It keeps on filling.
They can't fill the atria as well, because the atria can only fill as much as it has space for. So the lungs have plenty of blood, and so they're trying to fill the atria, but the atria isn't emptying. And so does the atria have as much space for this new blood to come into?
No.
No. So what the atria is going to say, I'm full, I can't accept more blood, so what's going to happen to the blood that's trying to get into it? It starts to back up in the lungs. So now my vessels and my capillaries and my lungs are like, hey, I'm swollen. I can't take, don't send any more blood through. I can't get out, the blood in my capillaries can't get out to my right atria as well, so things start to back up. Meanwhile, my right ventricle is trying to force blood out into the lungs. The lungs are already maximally full because the blood isn't draining out of them as fast. So if the lungs are already maximally full, what happens to the ability of the right ventricle to force more blood into the lungs?
Stop.
It decreases. Now, is there anything wrong with my right ventricle right now?
No.
My right ventricle is perfectly healthy, right? But now when it squeezes, the lungs are maximally full, and so when the right ventricle tries to push blood out, what happens to its ability to eject blood out? In other words, the afterload to the right ventricle has done what? The right ventricle afterload has done what? What was that? It increased, because the afterload is what it's pushing against. So the lungs are more full of fluid. The right ventricle tries to push more fluid into the lungs. The lungs said, I'm full. The afterload has gone up. What happens to the ability of the right ventricle to empty itself? It decreases. And even though there's nothing wrong with the right ventricle, because cardiac output, because stroke volume from the right ventricle has decreased, what have I just created? I started with left heart failure. What have I just created? I've also now created right heart failure. Yes?
So is that why patients with heart failure can get flat?
It's one of the reasons, yeah, because the fluid, and we'll talk about that, disperses. So the right heart failure, so left heart failure is the most common cause of right heart failure. Primary right heart failure is not very common. It can happen, but it's not very common. Most of the time you enter right heart failure because your left heart has already failed. But people say, well, if the right heart fails, then can that cause the left heart to fail? And the answer is
Yes.
no.
No?
The reason for that is the blood to the left ventricle goes to billions of capillaries throughout the body. And also, the lower limb vessels are known as what type of vessels? The lower vein vessels are known as what type of vessels? Was that?
Capacitant.
Capacitant or compliant. That's right, capacitant or compliant vessels. They are designed to hold blood as much as you give it. So as the right heart fails and the blood starts to back up, it's going to back up into our lower limb vessels primarily. It's not going to get to the point where there's so much fluid built up into the capillaries or into the tissue that the left ventricle can't overcome it. So right heart failure does not lead to left heart failure. Left heart failure leads to right heart failure. So I'll say it again. Right heart failure will never lead to left heart failure. Left heart failure will directly lead to right heart failure. Okay. So that's what this, when we go back to that, that's what this is saying. Chronic prolonged LV failure will lead to right heart failure, and that's the most common reason why right hearts fail. We can also separate heart failure into two types. And this is not just true for the left ventricle, but again, left ventricle is the most common type of heart failure we run into. So we can separate heart failure into two types, systolic or diastolic. And in reality, they're intertwined with each other. They're interrelated to each other. The question is, what problem is the patient experiencing? So systolic heart failure is heart failure that's caused by the ventricle's inability to contract. That's the most common type of heart failure we have. Okay. Systolic heart failure, what that means is the heart can't contract as well. So The reason this patient is having symptoms and signs of heart failure is because the ventricle is not contracting well. Diastolic heart failure is the ventricle can't relax or can't fill as well. With diastolic heart failure, if you're purely in diastolic heart failure, your heart can contract normally. Your heart's contracting normally, but the ventricle can't fill or relax as well. Okay? Systolic heart failure is I can't contract as well, and thus I can't push out blood to meet my body's needs. Diastolic heart failure is, hey, you can contract fine, but the problem is your ventricle's compliance. Remember we said that fourth factor, compliance. Your ventricle isn't compliant enough. It isn't able to relax. It's not able to stretch as much as I need to allow you to get more blood in. In most cases, systolic leads to diastolic, and that's the example that we just used a second ago. In most cases, a patient will start with systolic heart failure, and then they will transfer to diastolic heart failure. That's why they're kind of unified. But there are conditions where the ventricle's contractility is normal, and the patient's in heart failure because it can't relax and accept blood as well. That is a possibility, and there's certain conditions that can lead to that. As you can see though, the majority of our patients have what type of heart failure?
Systolic.
So the majority of our patients who go into heart failure, it's because the left ventricle can't squeeze as well. Only a small portion, it's not rare, but only a small portion of our patients go into diastolic heart failure. So when we talk about heart failure, we can have, again, systolic or diastolic. Systolic blood pressure can be one entire heart or one area. So it can focus on the left ventricle or it can focus on both ventricles. So you can have systolic failure of both ventricles. It's usually a structural defect, which means the muscle tissue itself, the structure itself is somehow affected. It doesn't mean genetic defect, it just means that the structure somehow is involved. There's something wrong with the structure of contractility. And this can also reduce blood flow to areas of the heart muscle itself, because if I can't push enough blood out, I can't push enough blood to the coronary arteries and it won't fill as well. Diastolic heart pressure or diastolic dysfunction. Inadequate treatment of high blood pressure is the most common cause. This is your body tries to manipulate the heart by hypertrophying or thickening. And then what happens is the thickness and the stiffness creates a problem. So what is this saying? What is diastolic saying? If we go back to our original statement, there are 4 factors that my heart has to manipulate to get a good stroke volume, cardiac output, and ejection fraction. What are those 4 factors? Contractility, afterload, preload, and compliance. Those 4 factors. Okay. If afterload gets too high, one of those factors is if afterload goes up, what happens to my ability of my heart to eject, to move blood? It decreases. Afterload, remember, is what my heart is pushing against. So if my afterload goes up, my heart has to waste more energy to try to get the blood to move, and we'll be able to move less blood. So if afterload goes up, the heart's going to start to fail. But to prevent that from happening, what my heart muscle will do is it will start to hypertrophy. And what does hypertrophy mean? Thickening of the muscle. How does that work? Why would that help?
It would increase the energy of contractility.
Explain that. How does hypertrophying help?
More muscle, more power.
Is it more muscle, more power? We don't add, when you hypertrophy, you do not add new muscle cells. Hypertrophying does not mean adding more muscle cells. That's not what happens. Hypertrophying, it means that the muscle cells you have thicken. The myofibrils thicken. The actin and myosin connectivity increases. Okay? So when you are hypertrophying muscle, you're not adding more muscle. In fact, you can't in your heart because new muscles can't grow. Cardiac myocytes do not regenerate. They do not spawn. They have no genosis or generation after structural development. Okay? They do not increase in number, but they can increase in density and size. So think about this. When you work out, what happens to your muscles? What happens to, if you work out a lot, especially with weights, what happens to your muscles?
Get bigger.
They get bigger, right? You get swole, right? They get thicker. You're not adding more muscle. It's just that the muscle cells that are there are thickening. The actin-myosin connectivity increases. You have more mass to each cell. You don't have more cells, you have more mass to each cell. And as you are exercising, as you are working out, as your muscles become more swole, what happens to the amount of weight you can pick up?
Increases.
It increases. You can do more work. Same number of muscles that you started out with, but those muscles can do more work. Does that make sense? That's why we work out with the same thing with your heart. As your heart overcomes an afterload, weights are an afterload. Weights are a resistance. They resist your muscle movement. That is an afterload. It's something that resists your muscle function. Your heart does the same thing. As it's pushing against higher and higher blood pressures, those muscles will thicken. And those thickened muscles will allow the ventricle a stronger contraction. And that stronger contraction should do what to blood movement? Should increase blood movement. Just like lifting weights, I should increase the amount of weights I can, and the distance I can pull the weights. As my muscles swell, I can increase how far I can pull those weights, right? Same with your heart. As it swells, it is able to contract and move more blood. There's a downside to that, however. Has anyone seen a bodybuilder walk? How do they walk?
Stiff, whatever. Broad as.
Right? And you're like, relax your muscles. And what do they say?
Cannot.
They are. And you're just like, that's relaxed. That was very painful. When your muscles become too swollen, they can't get into a nice, compliant, relaxed state. So when your ventricle muscles hypertrophy, yeah, they have a better squeeze, but the problem with that is to get that better squeeze, they sacrifice something, and they sacrifice compliance. So they can't relax as well. And if I can't relax as well, what happens to my preload? It goes down. What happens to my stroke volume? Then if preload goes down, what happens to my stroke volume? It goes down. What will happen to my cardiac output? It will go down unless it is compensated for my heart rate. Okay? So, it is possible to go into heart failure without a systolic problem. Because if your ventricle is hypertrophied, your muscle can do what really well? It can contract very well. Is that a systolic problem? No. The problem with hypertrophied muscles is that it can't relax very well, and therefore it doesn't feel very well, and you go into heart failure still. Does that make sense? So you can have two types. You can have systolic heart failure and diastolic heart failure. Most of the time, systolic failure leads to diastolic heart failure through congestion. However, you can have just pure diastolic heart failure from afterload and from ventricular muscle compliance. So if we go back to this, we can say the following. Systolic is the most common. Okay. So systolic heart failure is the most common. It's usually a structural inability to contract effectively for whatever reason. The ventricle muscles can't just contract as well as they normally do. Systolic heart failure generally leads to diastolic failure Through congestion, which means since the ventricle can't get rid of extra blood, that blood congests and gathers and prevents more blood from entering in, and we go into backwards or diastolic failure. Sometimes systolic failure is referred to as forward failure. Because my main problem starts off with the fact that I cannot push blood forward. You can have just diastolic heart failure. That is possible, just backwards failure. And if you have just diastolic failure, that is caused by the ventricle's ability to fill decreasing. In most circumstances, though, systolic failure will lead to diastolic failure in most cases. However, you can have just diastolic heart failure. That is still a possibility. We used to make a big deal about the difference between these. If you read your book, it's much more subdued. It hints at the difference of the two heart failures, but it's not as clear as, can you just have one or the other? And the answer is yes, you can have one or the other, but the majority of patients will start off in systolic failure and lead to diastolic failure. That is by far the most common cause. Diastolic heart failure by itself is not common, and therefore we produce less interest in it.
You can have both at the same time.
Well, yeah, because systolic will lead to diastolic.
You keep the systolic.
Yep, you don't lose the systolic. The reason why you're in diastolic is because you have systolic. Does that make sense? So most of the time, diastolic comes from already having systolic heart failure. And that's what we would consider a congestive heart failure. It's backing up. The problem started in your ventricle and it is backing up, congesting behind. So when you think about traffic congestion, like after you have an accident, people say traffic's congested. Well, traffic congestion means what?
You're not moving forward.
It's backed up, right? And it's backed up from the point of the problem. So congestive heart failure just means that we had a problem and the pressure and the problem backed up, causing more problems behind it. Okay? So congestive heart failure usually starts off systolic and goes into diastolic. Can you have somebody with congestive heart failure that just has purely diastolic? Yes, but the most common form is systolic to diastolic.
So when it says in that second slide that when you have a diastolic failure, your ejection factor is greater than 40%.
It can be, because if my systolic function is fine and I can increase my heart rate, what can I still do? Even though there's less blood getting into the ventricle the ventricle can still squeeze as well. So think about it this way. Less blood is getting into my heart, but what little gets into my heart will get out. And if I increase my heart rate enough, I can maintain a ejection fraction. Whereas with systolic heart failure, I'm not going to maintain this ejection fraction because the problem with systolic heart failure is my heart can't squeeze. So no matter how much blood I get in, I can't squeeze hard or fast enough to get enough out. So systolic heart failure will see a lower ejection fraction. Diastolic heart failure usually begins with a maintained or a higher ejection fraction. So we spent a lot of time with left ventricular failure. And so what can cause left ventricular failure? Well, these are. You don't want to work either now? Great. There we go, okay. So, how can we have left ventricular failure? How can my heart fail? Remember, I have 4 things: preload, afterload, contractility, and compliance. Okay? So preload, one of the things of heart failure is we can overfill the heart. And you might say, well, how can you overfill a heart? Regurgitant volume. So think about this way. Let's say your job is to build as many little models as you can in an hour, right? That's your job. Your goal is whatever I put next to you, you have all of the material I put next to you, you have to build a model out of all of that material in an hour. That's your goal, is to get rid of all of that material. Now, if you say, hey, I can do 100 models in an hour, no problem, and I give you enough material for 100 models, are you going to do good at your job? Yes, you're going to say, hey, this is not bad. If I put enough material for 1,000 models, are you going to be doing your job as well? Remember, your job is to get all of the models made in an hour, regardless of how much I put next to you. You have to turn all of that material into a model in an hour. And you say, I can do 100 models. If you give me enough models or enough material for 100 models, no problem, I can get that done in an hour. But I give you 1,000 pieces for models. Are you going to be able to get all 1,000 done in that hour? What are you going to be doing at your job then? You're going to be failing at your job. You're not able to do it. I've overloaded you. You're not failing because you don't have enough equipment. You're not failing because I haven't given you enough equipment to make a model. You're failing because I gave you too much to build models, and you can't keep up. And so the ventricle's the same way. If we give too much volume to the ventricles, guess what it can't do? It can't squeeze. It can't handle enough of it. It can't handle that. Remember, your actin and myosin have to line up perfectly, right? So as I stretch, if you remember physiology, as I stretch that muscle, remember Frank Starling's law, the greater I stretch, the greater the contraction, star to a point. So as I fill the ventricle, that muscle, those actin myosin fibers in that sarcomere are getting closer and closer and closer together. But if I stretch the muscle too far, what happens to the actin and myosin fibers? They slip, they don't line up anymore. If they don't line up anymore, what can't that sarcomere do? It can't contract effectively. And what will my heart do? It will fail. So volume overload. If I put too much on, too much is a bad thing. You always say there's no such thing as too much of a good thing, right? Not for your heart. If I give you too much preload, you're going to fail. I'm going to overstretch you. The actin myosin will not contract. Pressure overload. This is afterload. You can have an afterload failure. If you have high blood pressure, or if you have a valve that doesn't work and doesn't open properly, what's going to happen to the ventricle's ability to push blood? You have a higher overload, or you have a valve that doesn't work properly, what's going to happen to your ability of your heart to eject blood? It's going to decrease. Now we're gonna demonstrate this. Okay, Shema and Jen, you're going to be my demonstrators today because you're ill and I want you to go far away from me as possible. So, Shema, get up and stand up. Jen, just stand up inside the room for now. Go ahead and stand up. Shema, right now you're my left ventricle. Go ahead and stand up. Just for right now, stand here. You're my right ventricle. You're my left ventricle. That is your valve. Go ahead and open up the door to let us all out. We're the blood. Is it hard to do? Open it up all the way. All the way. Was that very hard to do?
No.
Could we all get out of that door right now? Yes, very good. Okay. Now, come back in, Shema. Jen, go outside and go on the other side of that door. And you're going to hold it closed, okay? Okay, so hold it closed. Okay, now Shema, you're the ventricle. Has the ventricle changed at all?
No.
Muscle has not changed at all. Go ahead and open that door. Come on, use all of your energy. Use it all. So it's a limit, right? There's a limit to what the muscle can do. Okay, so tell her to come back in. So the ventricle didn't change, the afterload, the resistance has changed. Okay, remember that's afterload. The resistance has changed. And what happened to my ventricle? The ventricle didn't change anything. The only thing that changed is the resistance to that ventricle. What happened to Shema? She could not, we would say she then did what? She failed. You failed. How does that make you feel? I'm sorry, that's a horrible word, but you're a failure. You failed to open the door. And it could either be because the door itself was not working. She could be a stenosis holding the door closed. Or she could just be the blood pressure holding the door closed. If either of those gets too high, the ventricle will fail to be able to open up the valve and push blood out enough to meet my needs. And that would be what type of failure? Afterload, or we have two types.
Backward failure.
Systolic failure, because it's a contractile problem. This one is what type of problem? Prelude. That's a diastolic failure. This one is a systolic. Well, this one's kind of a systolic. It could be both. But this one's kind of both. This one's purely a systolic failure. Okay. Another thing is we lose muscle. Muscle dies. Muscle becomes injured. Muscle becomes dysfunctional. The most common cause of muscle dysfunction is myocardial infarctions and ischemia. The muscle can't work as well. Okay. So this time we are going to have Tanya and let's see here, Stephanie. Can you stand up here for a second? The first one can be both. Yep, can technically be both. Because you're overfilling, which is a diastolic, and I can't squeeze because of the overfilling, so it's also a systolic. So I want you to be on the other side of the door, and don't put all of your weight against it, just kind of lean against it.
Is she pushing it?
Yeah, she's gonna push. Okay? Okay, so go ahead and lean against the door. Now watch what's gonna happen here. Just lean against it, not too hard, just lean against it. Close it all the way, just lean against it. And Stephanie, go ahead and open that door. Could you do it? Yeah, it took you a little bit, right? Okay, now we're going to change this. Shema, get up and try to open up the. Now let's look at the difference between Shema and Stephanie. What have we lost here? I'm not saying anything bad.
Or mass.
We're losing mass. Yeah, we're losing muscle mass too. So now, as we have lost muscle mass, now try to open the door.
With all my energy.
Yep. All right. Yeah, it's very hard, right? Okay, you can come back in. Okay, so go ahead and sit down. So when I lose muscle mass, when I lose muscle, because it died or it's become ineffective, it's a systolic failure. I can't push the door open. In this case, did the afterload change at all? Who was always on the other side of that? Tanya was always on the other side. You didn't change at all, did you? Okay, no. What changed? The muscle mass. So it's a systolic failure, not because of afterload, just because the muscle itself is dysfunctional. And then we have this thing called restricted filling. And restricted filling is the ventricle can't relax. So restricted filling is truly pure diastolic. So this is where we get into our pure diastolic failure. In these cases, the ventricle itself can contract vigorously. There's no problem with afterload. There's no problem with the amount of muscle that I have. With restricted filling, this is pure diastolic failure. So this is systolic failure, systolic failure, systolic and diastolic failure up there. This is pure diastolic failure. As you can see, there's very few things that can actually cause pure diastolic failure. These things prevent the ventricle from filling well. The ventricle's contractility does not change. Okay. So we're going to go to this. So we're going to take a break here. We're going to come back and talk more about, now that we've that was weird. We're going to take a break. When we come back, now that we've talked about the different types of that, we're going to go and talk a little bit more in detail about heart failure and these different types and what it causes in our body. Okay, so let's take a quick break. 4 or 5 minutes.
that time we keep it like, so what time now? Like,
I don't
is
know,
it
3
like
hours, that is
a lot.
I mean, versus
not for me.
challenge for
Yeah.
us,
Test.
Me too, like,
obviously,
taking like
because
5 hour or whatever.
Yeah.
it's gonna be more challenging,
Exactly.
so.
Forever, 3 hours doesn't seem like it's gonna be enough time.
That's kind of, we did no fuck before you took the test, you sure?
One time I took a test and had my kid, it took me like 9 hours. I kept going back, I'm like, the mouse.
Yeah.
Yeah.
I'm the same way. Yeah, it's no time to do it in the last semester.
Hopefully there'll be, repeat questions from the other exam.
Yeah.
I always pull up all those questions and have them open.
Yeah, we do.
So we can start at any time we want.
Yeah, I think the test opens today at like 12.
Yeah.
I
And
don't
then I
know,
think
we can
it's,
start at any time we want, but it's a, it's a.
yeah, I think there's been a week to do it, and it's due on the 26th.
Oh,
I think
really?
that's what it said.
26.
Oh,
Yeah.
really?
Yeah.
Did you say a week?
That's what it shows on the thing.
No, I mean, like, when you start the
Oh.
exam, you have 3 hours to
Okay.
take it, but I think you don't have to take it like today.
Yeah.
Um,
I think it said it's due on the 26th by whatever, 8 AM.
So, yeah, no, it says before 9 p.m.
It's,
That's weird.
it's not due
Before
tonight.
9 PM?
Yeah, it says 8:59 p.m.
It's due tonight, right?
Maybe he meant to say
No.
on
AM.
26.
I think it's the 26th.
just
I don't think you
opens
have to
today.
take it today.
You don't have to, yeah.
Yeah. I mean, I'll confirm with him, but I don't think you do. I think you have all week.
I'm not gonna go to clinical and take that test though, so I'm gonna have to figure it out.
I'm either gonna have to knock it out today, or I don't know if I can do it.
Thinking,
this
we
weekend.
just like get it over with today.
Yeah, if I can grab a 3-hour block and then
I mean, it's not like I have to study for it now, just gotta get on it.
yeah.
It's only 38 questions.
Only
It's
38?
It says 38 questions, but it's 72 points.
Oh.
Oh, there's math.
Yep.
There's math. Shit.
Isn't that, there we go.
Fill in the blanks.
Oh my
Yeah.
God, I need more
It's the
time.
fill in the blank ones.
Select all that apply.
Maybe just label the heart. And then
I don't know why, but I keep getting those stupid valve ones wrong. I don't know what I'm putting in there wrong.
Is it, cause it's the
Yes.
left and the right?
I don't know if, what I'm asking, cause I'll specifically say like open pulmonic valve. I don't know if he's wanting me to put like semi-lunar, is that why I'm getting it wrong?
No, they're the cusps, the
I
commissure
don't
and
know what the hell, but I'm
annulus.
like, this is an open, pulmonic or aortic valve, I'll say that, and I'm getting them wrong, and I don't know why.
Is it for like the leaflet one, or was it for like just
I
the
don't-
heart labeling?
I get all the heart label, I got all those right, but there was like one label all the parts of the heart, and then the one below is like label the valves, and I'm like,
Yeah.
clearly I just answered it up here, okay, but down here it's not right, I don't understand.
It's the leaflets and then the annulus and the commissure, whatever.
That's what
how you
he's
say
wanting,
that.
cause it's not telling me the answer, so I just keep.
It's like specific to wherever that arrow touches and the
Oh.
color. So if the color is
That's
like
okay.
green all the way around
I'm
it,
like, this is getting ridiculous, because I don't know what the hell's going on, I'm answering it, and I know for a fact, I know what that valve
Yeah.
is,
yeah.
and I
I'll
don't know.
clarify with him just to make
Yeah.
sure. So like in the future, like if he does
Yeah,
it
it's
again,
such a
he'll-
stupid thing to get wrong.
Yeah, I
It's
think
frustrating.
that's what they were, was the
Yeah.
annulus, commissure, and that specific leaflet
Leaflet,
of
okay.
it.
Oh, Jesus, this is retarded.
And I always, like, like I was telling Tosha, describe it, I will put exactly which valve it is.
Yeah. So
if
it was
it's
the same
left
thing
or
for me.
right,
I just wrote right and left,
Anterior or posterior.
and she wrote anterior and posterior, and she got right, and I
Yeah.
just wrote left cusp, right cusp, and I got wrong.
Okay.
And I'm like, so it is not anterior, it's not posterior. I could see them clearly to be right and left.
Yeah,
And she said no, she always writes posterior or anterior, so.
Cause it's
Yeah.
left and right.
But see, the
Like
thing
left
is,
anterior, right
and it is
anterior.
not even
Exactly.
that, like my
Yeah.
previous test with just right and left, I got them right.
yeah, I was just
And
telling
then-
them, I'm like, I don't know what the hell he's asking for, like,
I think like every single cusp has like 4 words to like,
Yeah.
to
Yeah.
like tell him, this is a pulmonary.
Oh, by the way, I'm
Anterior.
getting the book delivered today.
Oh, good.
I was seeing just now, I watched the USPS tracking,
Yeah,
it is coming today.
fun,
Fun, yeah.
love it.
guess what I'm getting on? Getting on that weight loss medicine. paying a lot for it, but,
Oh, Ozempic?
well, it's a compound, so Similar or whatever.
They took away from the daycare part, now I cannot get my Ozempic anymore.
Yeah,
So I'm going to wait for a
but-
year or,
That's exciting. I like it.
I don't know
I
what
don't
else
like
to
the
do.
straight ones,
It's
that's
scary at this point. Usually I could like work out, eat right, lose it slowly, but no, there's nothing.
Yeah,
It's
you're
just like,
changed
come fast.
now. Yeah, you're changed.
oh, it's so scary. So,
Look
but
what,
I found this place called Native Med, and so for a month of it, it's $262.
come here,
That's crazy.
come here.
I need to send you, I keep forgetting, I need to tell you the 35.
Whoa.
35.
Yeah. See, I thought, I'm trying to buy them for my graduation thingy.
Oh my gosh, you be fancy as hell.
How is it? This?
Way fancier than me.
Or, shut up, you know this.
I was late, so I don't even know if we really want me to do it.
Oh, they will let you do it.
I forgot, and I was like, shit.
You can still
So
do
the
it.
18th.
What do you say?
Who's the first one again?
This one? Okay. It's not still done.
Hmm?
It's still not done.
I like that color.
I like the color too.
That's a little too Christmassy for me.
Me too. But that's what my husband likes.
Okay, that's green.
But they say, okay, so here's a deal. If you're trying to buy the graduation clothes from the Hillsborough bookstore, it is too costly. It is like $54. But from Amazon, it is $19. So try to buy from Amazon.
What, the cap and gown?
Yes,
Is it the same color?
Yeah, it's navy blue.
Same.
It just says navy blue, yeah.
Well, we can all do the same color if we buy from Amazon.
Yeah,
At least ours is
Sending
black.
you the link. Yeah.
Yeah.
I can share the link, yeah.
Sure.
Yeah.
Please.
You know what I'm running? I have a check today.
Stacy might have that idea. Huh?
It was
close. I
This is
know.
your number, right?
I
I
know,
know
but
that
it's
it's
on
on and said, let's go eat.
Yes,
Chick-fil-A,
you
so
got
I drove
that right.
down Boyette.
Yeah.
There was one there, but I was like, oh,
It's not here.
there's- so when I go back home, I said, let's find something else. And I went out later, cause of traffic. Then we see the Chick-fil-A open, I'm like,
Finally open, yeah.
I really, let's just get Chick-fil-A, let's just get these. Cause they were like, McDonald's, and I said, no, I'll
It was
cook.
like closed for like several weeks and my kids were like gonna die.
What?
I'm gonna tell you.
Withdrawal.
Or your cash is better.
Whatever, I don't care.
I said that, I love the fries. I have this thing with the Chick-fil-A fries and salt and ketchup.
So I have four choices. Okay. You like this combination? Because it looks. Oh. That's what I'm thinking about right now.
What is that, you're drinking? It is a caramel cordial shake.
Oh,
Is that
okay.
Starbucks? No, it's Einstein.
I like the gray thing.
So I heard like a Van Hill pay better than a hospital.
Advent?
Yeah.
Yeah, I know a girl that, she works there, she's only been doing it 3 years, and she makes 45
Yeah.
an hour.
Yeah, it's gonna find out from like one of my what's called like workers who have at my hospital. It's like
Yeah.
they offered me a job, but it's like no man, it's like HCA like kind of offer kind of low, you know, like it's like whoa, a Van Hill offer way better.
Yeah.
And they talk like maybe have to deal with like stock thing, like I mean HCA more like a private stock, and then like Van Hill more like public, so like you know it's like how like I said whoa, this is great. I'm like,
Yeah, I mean, everyone's really nice.
Yeah.
Yeah, if you live in the area, I would definitely try for them. Definitely can't do that, but,
It's over 3 hours, but it's only.
I wish I could, because I really.
I mean, like $40 now. That's like,
3 years.
Until Monday.
Until Monday.
Yep.
I mean,
So one
but
will
the
start
funny
in
like,
3
like
hours?
Yep.
the problem when after you graduate, they only like up the low, right? I mean, they don't go up.
There was a
The,
girl that was in the program, this last time.
Yeah.
And they started her without having passed her exam, like $30.
What's that?
He was talking about Advent pays better than people, and I was just telling him that people that I had worked with said that they had gotten paid a certain amount.
we were talking
And
about.
like Jess, she hadn't even passed her exam yet, and they offered her $30, and then once she passes it, they'll raise it up.
Mm.
Okay.
Just go $5 to $10 more.
Yeah?
Yeah.
For
So
what?
no until like,
They just
next
raised
chat.
the, no, she told me she got the check this Thursday.
our people don't get it for a
Don't
while.
don't get what?
The raise that is,
They just had the raise for the daycare, which ranges from $5 to $10. It's not in percentage this time for them. So it depends on the amount of years of experience that you have. That's what they are going to get.
Mm.
And again, daycare is rolling it up based upon hospital.
Yeah,
Hospital determines, their own HR department determines how
yeah.
it's.
So it's again, different hospital has different thing.
Why are you?
Baycare, man, how was the good pay right there?
I think Advent is the best pay.
The best pay, yeah, I heard all the time about
They
it.
all say Advent is the best pay, but
One of my buddy is the same thing too.
because it's a private owned company and whereas daycare is like a joint sector thing.
And they're hiring.
Cannot.
Everyone's hiring right now,
Mhm.
because there's a dearth of people working.
I think all those travelers trying to get some people that are just.
Yeah, they're trying to get rid of as many travelers as they can, because it's not cheap.
Yeah.
I don't know, they get paid like what, double something?
Yep.
Yeah. That's,
There's a traveler at one that gets $55.
Really?
So,
my buddy say you pay like $70 now.
Oh, she set it up this way, I have no idea why she did this.
there's no association there, but over here.
Okay, so, I'm not gonna look at that, that's too small. Yes, sir. So this is the this is the types of systolic and diastolic failure. Can you hit the back two lights for me? Okay. So when remember, we have these different things. We have contractility, afterload, preload, and compliance. So when we talk about heart failure, we have one which is reduced ejection fraction. That's what we call systolic dysfunction. You are entering into heart failure because you can't pump out enough blood to meet your body's needs because the contraction of the heart is poor. So we call that systolic failure. And with systolic failure, these patients have a decreased ejection fraction and will also usually have a decreased cardiac output. Not necessarily, depends on their heart rate, but at least a decreased ejection fraction. Remember, ejection fraction is the efficiency or what percentage of blood it gets out every beat. If you have a poor stroke volume, your ejection fraction will suffer, but if you have a fast enough heart rate, you could still have a normal cardiac output. Does that make sense? So with heart failure, we don't look so much at cardiac output, we look a lot at ejection fraction. How effectively can the heart pump out blood every minute? Or excuse me, if every beat, what percentage? So we have impaired contractility, okay? The ventricle can't contract, or it can't contract because there's too much volume. So in other words, we have ischemia and infarction. The heart doesn't get enough oxygen, the muscles don't have enough oxygen, they cannot contract as well. Remember, to get contraction, you need ATP and ADP. That is that energy that is produced by the mitochondria. Mitochondria creates ADP and ATP from oxygen, metabolism. And if I don't get enough oxygen, I can't create enough energy sources. If I can't create enough energy sources, and I cannot utilize those energy sources, my contraction goes down. Also, if I'm overloaded, if my actin and myosin slip, can I contract as well? No. So if I'm volume overloaded, my contractility goes down. Okay? I can't contract as well because I'm overloaded. from regurgitation. And there's something called dilated cardiomyopathies, and we'll talk about those next week. Dilated cardiomyopathies is a pathology of the muscle cells directly. It's a direct pathology, and we'll talk about those more next week. Or we can have a systolic dysfunction because of afterload issues. The afterload is too high, so even if my muscles were functioning properly, they can't create enough force to move the blood. And those cases, as we demonstrated with the door, is either because of severe hypertension, there's too much resistance on the other side because of the arterial resistance, or advanced aortic stenosis. Diastolic failure is pretty confined, if you notice. There are very specific things with diastolic failure. Diastolic failure is not as common. We have left ventricular hypertrophy and restrictive cardiomyopathy. These are both cardiomyopathies, and again, we'll talk about both of these next week, okay, on Monday. Myocardial fibrosis. After infarction, after I infarct, remember this, the end of infarction is fibrosing that dead tissue. That dead tissue scars over, and scar cannot stretch as well. Scar is a fibrotic protective tissue. It doesn't give, it doesn't have any elasticity to it. So the ventricle can't dilate as well after an infarction. It can't stretch as well because of a scar. Transient myocardial ischemia, so it's kind of funny. Myocardial ischemia can decrease contractility, but it also can decrease its ability to relax. You kind of get hit in both directions with ischemia. And then again, pericardial constriction and tamponade we'll talk about next week. That's another pathology that is very specific. So if you notice, my systolic are much more common problems that we see every day. Myocardial infarctions, valve regurgitations, valve stenosis, hypertension. Those are common pathologies, right? If you see most of your patients that we see who have heart failure have had myocardial infarction, they have ischemia, they have a high blood pressure, or they have some sort of valve disease. Those are the common causes. So systolic dysfunction, systolic heart failure is by far the most common thing you'll see. Diastolic dysfunction is very specific, and that it's usually cardiomyopathy or pericardial pathology, and only after the MI do I have the fibrosis of the tissue that won't stretch. Okay, so not as common. So that's primary left heart. Now, if you look at the right heart failure causes specifically, so this is kind of mainly focuses on, if you notice, this mainly focuses on left heart failure because it's mitral and aortic regurgitation. If we look at right-sided failure, the reason the right heart fails, what's the most common reason? It's listed in order. What's the most common reason? Left-sided heart failure. If your left-sided fails, remember we talked about it congesting and backing up. The right side can't fight off the left-sided failure, so it will back up and cause right heart failure. It's the most common cause of right heart failure is when the left heart fails first. However, the right ventricle can infarct, and just like the left ventricle, that would lead to a systolic dysfunction. Pulmonary valve, not common. It can happen. It's not common for the pulmonary valve to become stenotic, but it can happen, and that would cause a systolic dysfunction. Then we have very specific, less common problems associated primarily with the lungs. COPD, interstitial lung disease, sarcoidosis, that is a disease that we'll talk about with heart failure, or excuse me, with cardiomyopathies. Sarcoidosis is a protein that builds up in tissues and makes them hard and stiff. Chronic lung infection, chronic pneumonias, chronic bronchitis, chronic things that causes the lungs to become more resistant. Pulmonary embolisms and pulmonary hypertension, very specific, and those are less common to occur. Matter of fact, pulmonary hypertension, primary, what we call essential pulmonary hypertension, very uncommon, does not occur very often. We usually see pulmonary hypertension because of left-sided failure. We don't, it's not common to see pulmonary hypertension in the average patient. We're going to talk about that's not always true, but it's not common, especially in Florida. Seeing primary pulmonary hypertension is not common. in Colorado, especially in the mountain communities, primary pulmonary hypertension is more common. But in Florida, very uncommon.
It's just like altitude issues?
It's altitude issues and what the lungs have to do in order to allow maximum oxygen to diffuse through it. So it is altitude issues that are associated with that. But if you notice, they're very, very specific and not very common. COPD, matter of fact, if we could give her a smoking, what would happen to that cause?
Decrease.
It'd almost go away. Interstitial lung disease, sarcoidosis, is more of a genetic disorder, so not really common. Chronic lung infections, bronchiostasis, people who have kind of like strep throat for very long periods of time that then penetrate and become bronchitis. Not common, not very common. Just have to throw that out there, encouraging you to take care of yourself. Pulmonary embolism, that's a little bit more common, but it's more common in patients who have low lifestyle, do a lot of traveling and things like that. It's a very specific group of individuals, unlike left heart failure where the group of individuals that are affected by it is wide open and much more common. So some people always ask, and this is very important, your book kind of touches on this and kind of runs from it, but people always ask, well, volume overload doesn't make much sense. How can volume overload create problems of failure when the Frank-Starling's law is in effect? Frank-Starling's law says the more I fill, the better my contraction, to a point. We already talked about the slipping of the actin and myosin. But this picture from your book explains, unfortunately, what happens with this. So my stroke volume goes down for a second. So my ventricle does not empty itself as well, because remember, when stroke volume drops, that means my ventricle did not get as much blood out with that last beat compared to what it normally does. So my stroke volume in one beat drops for a second. That means my ventricle's emptied less, which means I have more volume in my ventricle, which means the next time the ventricle fills, the ventricle will fill greater than normal, and what should happen to my contraction? It'll increase. Very good. As my stroke volume goes down, some neurohormones are activated, and we'll talk about that in a second. That will cause that neurohormone response, that norepinephrine response, the renin-angiotensin response, causes the muscles to try to hypertrophy a little bit, to get a better squeeze next time. And what will that do to my stroke volume? If the muscle cells start to hypertrophy over time, what will happen to my stroke volume?
Decrease.
No, it will increase, because remember, hypertrophy increases contractility.
Oh, yeah.
The problem with both of these, however, is increasing in diastolic volume means my atria can't empty as well. Increasing hypertrophy means my atria cannot empty as well. So as my ventricles increasing stroke volume, what's happening to my ability, to the ability of my atria to empty?
Decreases.
It goes down. My muscle gets thicker, I have less space for the atria to fill. The atria is having a more difficult time emptying into the left ventricle. If my stroke volume goes down for a second, there's more volume left over in my ventricle, the atria can't fill that ventricle as well, because there's more volume left over, there's not as much room for the atria to fill. So the atria starts to increase in pressure, and so I'm able to maintain my stroke volume, so these two kick in and maintain my stroke volume, but what's happening to my diastolic heart?
It's failing.
It starts to fail. So Frank-Starling's law is great. It will increase your stroke volume, it'll increase your cardiac output, it'll get your ventricle to empty better, but in doing so, there's a cost to it. If that cost goes too long unpaid, my atria will start to fail and I go into congestion. I start to back up. So yeah, Frank-Starling's response will increase my stroke volume, but there's a price to be paid. The greater I fill, the greater my contraction, to a point, but even under that point, there is a negative effect that it plays on the ability of the diastolic heart to fill.
How long does it take for this to occur
Normally a long time. Normally this takes a significant amount of time, years generally. There's something called rapid heart failure. When you have a massive MI, you go into rapid heart failure, or what we call acute heart failure. That's not common. Most patients in heart failure have been, just like coronary artery disease, you've been working at this for a while. You've been building this up for a while. It doesn't happen overnight. Okay. So, sorry, I haven't slept. Give me a second here. You go into heart failure. Your cardiac output starts to drop. Your body steps in and says, hold on, I got this. I'm going to make things better. Okay? I'm going to make things better. When your cardiac output drops, when your stroke volume drops, when your ejection volume drops, the perfusion into your tissues will also start to do what? It'll drop. If my heart can't get it out, can my tissues get it in? No. So the perfusion starts to drop. Your body says, hey, I'm going to fix this. No, you're not. Your body steps in and says, I'm going to fix this. Your body does not understand that it's your heart that's failing, because according to your body's design, what is never supposed to fail? The heart. Because if your heart fails, what happens to all other systems? They all fail. Remember, that was one of the first things we talked about in homeostasis. So your body's response systems are designed based upon the fact that your heart can't fail. And we know that's not real. It's like your arteries. Atherosclerotic process is caused because your body's set up that your endothelial cells will never fail. If your endothelial cells never fail, all of those steps on forming a plaque, would any of that occur? No. The only time those things would occur is if you got a hole in your artery, and those steps that causes an atherosclerotic plaque are designed to fill a hole up. Your body's it was not designed with the thought that your endothelial cells could fail without a hole, without you being cut. So all those processes that we say, oh, that causes atherosclerotic plaque, that's true, but they're really there to stop you from bleeding out. Your body doesn't have a design saying you could have an endothelial failure without bleeding out. It doesn't know that. So the same thing happens with heart failure. Your body does not know that your heart can fail. Your body makes an assumption that the heart doesn't fail. So all the systems that are built in when your cardiac output drops, all the systems built in assume that the problem's not with the heart, it's with something else. So we have a decreased cardiac output caused by heart failure. Well, who steps in to try to fix this problem? We have the sympathetic nervous system, which is our boom. Oh, there you go. The sympathetic nervous system, your fight or flight, right? You're welcome. Now you're all awake. Good morning. Okay, your sympathetic nervous system kicks in because what it's saying is, oh, you're not circulating enough volume. Your heart's not working hard enough. We got to make it work harder. Heart, you can't fail, but we need you to work a little bit harder for us. Get going, get going, get going. Without realizing that the heart's working as hard as it can. And what is the sympathetic nervous stimulation going to do to that poor heart?
Make it work.
It's going to make it work harder, and it already can't do what it's supposed to do. Okay. Meanwhile, the kidneys step in. The kidneys step in and say, I'm not getting enough fluid pushed to me. Can't be the heart's problem. What's my problem then? Yeah, it's a volume problem. This patient doesn't have enough volume, or the arteries aren't constricted enough. I need the arteries to constrict more, and I need my body to retain more volume so that the heart can circulate it better. What's the problem with the heart right now? What can't it do? It can't circulate volume. So the kidneys come in and say, I'm going to make things better by holding more volume and getting blood vessels to constrict more, because that must be what the problem is. Well, if my heart's already failing because of high blood pressure, what will constricting the vessels do?
Increase.
Make it feel faster. If my heart is already overwhelmed with volume overload, what will increasing the volume do? Make it fail faster, increase the overload more. Are any of these things helping really? Meanwhile, your brain kicks in because of the renin-angiotensin system, antidiuretic hormone, ADH, created by the pituitary gland, because of aldosterone, comes in and says, hey, kidney, I'm gonna help you out. We're gonna absorb more fluid. I'm gonna make you absorb more fluid because there's not enough fluid coming to the brain to perfuse the pituitary gland. So we need more fluid to create the pressure to perfuse the pituitary gland, hold more fluid. Increase contractility, increase heart rate. Okay. They'll increase my cardiac output and increase my stroke volume. That's going to help for a short period of time. Vasoconstrictions increase my blood pressure, increasing the afterload. Venous constriction decreases venous return to the heart to the preload. Well, that's going to affect my stroke volume. But all of this kind of ends up in doing the worst. It's going to cause failure. It's trying to do this. It's trying to increase my stroke volume and it's trying to increase my cardiac output. But the majority of the effects that it causes, arterial constriction, increased venous return, increasing circulating volume, these effects here are going to lead me to worsening failure. So when you have decreased cardiac output because of heart failure, all the systems that your body has built in, almost all of them will lead to us having worse failure. Increasing contractility and increasing heart rate may have a momentarily increase. It may momentarily improve, but more blood going out to the body increases my blood pressure more, which is going to cause more higher arterial pressures, and I go into this 6th cycle of death. Heart failure does not get better on its own. Once you enter into heart failure, we're actually working against the body to try to get you out. Does that make sense? Your body's natural inclination, once you go into heart failure, is going to make things worse. Which is why when somebody goes into heart failure, what we're going to be giving them in medications are usually what? Diuretics. Get rid of all of this, right? Beta blockers, slow down the heart rate. Decrease the heart rate a little bit so that it can have more time to fill, more time to squeeze. Decrease the contractility a little bit to decrease a little bit of the arterial constriction and blood pressure. Calcium channel blockers decrease the vasoconstriction. We're working against your body. When you go into heart failure, your body's actually making things worse because of its natural program. We have to go in there and try to somehow negate the natural effects of your body. Now, people will be in heart failure for a long period of time, and I like what your book does here with this graph. People will be in heart failure for long periods of time, and they won't go in because they don't realize they're in heart failure. We'll talk about the signs and symptoms in a second. We usually stumble on heart failure by accident because something has happened that increases or worsens the heart failure. The body's metabolic demands increase. So when you go into heart failure, most patients who go into heart failure will tell you, what do they feel like doing throughout the day? Nothing. Yeah, that's right. I'm just gonna sit in my chair and watch TV all day. Okay. When we go to heart failure, what are things that all of a sudden will bring that patient to us? They get an infection. The infection process, your body trying to fight off the infection, will increase the metabolic demands, the demands of your tissues for more oxygen. If your tissue demands more oxygen, what is your heart going to have to do? Work harder. If you're in heart failure, what can your heart not really do? Work harder. What's going to happen to their symptoms? Increase. I can't breathe all of a sudden. I pass out. Anemia. Your oxygen carrying capability of your blood goes down. Therefore, to meet your metabolic needs, what do we have to have that blood do? Since it can't carry as much per unit of blood, what do we have to have that blood do? How are we going to perfuse it more?
The red blood cell.
Is that?
Circulate.
Circulate it more. Because I have fewer red blood cells, I gotta get those red blood cells to circulate more often, which is gonna make my heart do what? Work more. What's gonna happen to their symptoms? It's gonna increase. Tachycardia. Tachycardia is directly making the heart do what? Working harder. Gonna have an increase. It can't work harder, we're having an increase. Hyperthyroidism is the TSH, thyroid stimulating hormone, T4, T3 is a metabolic, your thyroid is your metabolic command unit of your body. If you have hyperthyroidism, it's dumping these hormones into your body, and those hormones increase your metabolism, which means it's also gonna cause your heart rate to do what? Increase. That's right, hypothyroidism patients have really high heart rates. If they're already in heart failure, what's their heart going to do? Work harder and fail more. Okay. Pregnancy. Does anyone have a question of how pregnancy would cause your heart to work harder? There's a lot of stuff going on, right? You and fetus need nutrients, so it works harder. Their sodium content goes up, or they drink a lot, or they enter into renal failure. This all increases your preload. If your heart can't handle the preload already, it can't handle the volume that's already entering into it, what's going to happen if I add more volume? It's going to get worse. Sodium, remember the idea, so wherever sodium goes, who follows it? Water. So if you increase your sodium intake, your kidneys will naturally hold on to more sodium because they can't filter it all out. And if your kidneys hold on to more sodium, what happens to the amount of water your body holds on to? It increases and your heart failure gets worse. Hypertension goes up. As your blood pressure goes up, what's going to happen to your ability of your heart to push against that hypertension? Decreases, and I increase my failure. Okay. So I could go down on all of these. They're put on a medication. They have a little ischemic. They're alcohol. I think it's something called alcohol heart. These things, once the patient changes their physiology slightly, all of a sudden they start to notice, I can't breathe, I'm short of breath, I'm more exhausted, I can't do as much, and then we see them. You can slip into heart failure very easy without noticing it because naturally what do you just do? Was that? Yeah, how would you compensate for your heart failing? What would you do or do less?
Less work, rest.
More rest, less work. I'm tired all the time. It's kind of funny. The coolest thing that happens is after a bypass surgery, and I just had a close friend of the family have bypass surgery. And it was funny because when he went in, he was categorized in heart failure. He started having chest pain when working out, and they did the coronary angiogram. Actually had 6 vessels that were blocked. Had a quadruple bypass with a couple jump grafts to a couple of the different, and wide grafts to a couple of different vessels. Fantastic, creative surgeon. But when he woke up, or actually when he was released from the hospital last week, the funniest thing was he said, I'm not as tired anymore. He's like, I have energy. I want to go for walks now. He said, why? And I said, well, you were in heart failure. Your heart wasn't getting enough oxygen, so it couldn't beat and contract hard enough to maintain your body's needs. So what does your body do? Your body doesn't assume your heart's wrong. Your body just says, I just can't do as much as I used to. And you naturally get exhausted and tired. And now that your heart has all that oxygen, what have we reversed? Since the muscle gets all that new oxygen, it can do what better? It can contract and squeeze better. And all of a sudden, what happens to that heart failure? It starts to reverse. It goes away. It wouldn't do it on its own, would it? Heart failure is what we call a condition. It's not a pathology. Okay? What's the difference between a condition and a pathology?
Condition something you can fix, right?
Not necessarily, because I can't fix heart failure. I can fix what causes the pathologies that cause heart failure. But I can't fix heart failure.
Pathologies are the reasons for
So
that.
the condition is the outcome. It's the end cause, the end outcome. So you go into heart failure because you have one of these other pathologies. Does that make sense? one of these other diseases. A condition is a group of problems gathered together due to a cause. So heart failure isn't we can call it a disease, but it's not really a pathology. It is a condition caused by other pathologies. I can't come to Shema and say, I'm gonna fix your heart failure. Because what does that mean? Well, what that would mean is I'm gonna make your heart pump out more blood to meet your body's needs. That's what that term means. I'm gonna fix your heart failure. I'm gonna make your heart pump out more blood to meet your body's needs. Well, what does that even mean? Well, to get that to occur, I have to fix an underlying problem, whether it's a valve, hypertension, ischemia, or an underlying, pulmonary embolism, an underlying disease. I can't just magically make the heart pump out more blood. There's a disease, a pathology that's causing your heart not able to be pumping out more blood. So heart failure is a condition. It's not a pathology. So I can't fix heart failure, but if I fix one of these conditions up here, what will I do to the heart failure? If I can go up here and fix one of these conditions, what will happen to my heart failure? Left heart conditions, right heart conditions. My heart failure will reverse. You can't reverse it on its own.
So what's pathology then? That's a totally different thing.
What's that?
Pathology, like.
Pathology is a disease that causes suffering. A condition is the outcome of that suffering. So pathos means to suffer. So pathology is the study of what causes you to suffer. A condition is what is your suffering. What has happened because of this pathology? You're suffering from heart failure. You have a condition called heart failure. I can't fix the heart failure, but I can fix the underlying pathology. So symptoms. People flip this. So I want you to pay attention to this chart because people flip the symptoms. Don't do that. What do I mean by people flip the symptoms? When I talk about right heart failure, and I ask people very commonly, what are the symptoms of right heart failure and what are the signs of right heart failure? They start talking about the lungs. They say, well, I'm going to have breathing difficulty. I'm going to have fatigue. I'm going to have something called paroxysmal nocturnal dyspnea, which means I have difficulty breathing when I sleep, also known as sleep apnea. When I stand up or change position, I have difficulty breathing. Oh, well, then what's your signs? Well, fast heart rate, sweating, pulmonary sounds, pulmonary crackles, loud P2 or A2 pulmonary sound. I'm going to get an S3 gallop, S4. Those are all lung conditions. But remember, the problem is always behind it. So a right heart failure means it's having trouble pushing blood towards the lung. So where's the problems actually going to be found?
In the lungs.
No, behind it. With heart failure, your problems are always found backwards. It's like when you have an accident on an interstate, where's the problem? Is the problem, if you're in front of the accident, do you have to worry about it? If you're coming to school and there's an accident on the I-4, I-75 interchange, and you've already passed that interchange, is that accident any concern of yours?
No.
No. You're gonna have smooth sailing, right? Probably even better, because you're not part of that mess. But everybody from that condition, from that accident, backwards is now what? They're stuck. They have a problem. So the right-sided failure can only affect what is behind the right heart. It can't affect what's in front of it. It can only affect what's behind it. That's true of any disease. Any disease can only affect, of the heart, can only affect what is behind it. It can't affect what is in front of it. So with right heart failure, do I have any lung problems whatsoever?
No.
No, I have no pulmonary issues because that's in front of the disease. The lungs are perfectly fine. There's nothing wrong with the lungs at all. The problem is going to get back to the heart. And so where's my problems of my right side of my heart going to be? What's that? The peripherals, the legs, the abdomen. It's going to be harder, it's congestion, it's going to be harder for that blood to get back. So we're going to see the symptoms of the patient being more systemic. So the right heart failure causes systemic problems. Left heart failure causes what type of problems? Well, what's behind the left? The lungs. So with left heart failure, I will have pulmonary problems and pulmonary findings. With right heart failure, I'm gonna find systemic problems and systemic findings. Right-sided heart failure, the most common thing that people complain of is leg swelling. Cankles, they're like, I can't fit into my shoes. I walk like 3 blocks, all of a sudden my feet are like pouring out of my shoes. It does happen, there's not much swelling. That would be a sign of right heart failure, not left heart failure. Oh, my upper right quadrant, right up here. Lower right quadrant, we worry about appendicitis, but upper right quadrant, I have pain up here. And we feel for the liver is enlarged. Why is the liver enlarged? What can't it drain out?
Toxins.
Well, no, it's not toxins. What's building up in the liver?
Buttons.
Blood. Your liver has, remember, in your systemic system, your liver at rest receives the most blood flow. Because everything has to go through the liver to be detoxified. And if that blood flow can't get back to the right atria, what happens to the blood? It stays and the liver becomes edemic. The liver enlarges. And so they'll get pain here. The jugular veins will start to distend. We've talked about this before. When I'm standing up, should you see my jugular veins?
No.
Because gravity is helping that blood do what?
Oh, no.
Drain right into my right atria, correct? If my right atria is filled, can that blood get into my right atria anymore? So what will happen to my veins? They'll start to swell. And again, peripheral edema, hepatomegaly. Hepato is liver.
What is hepato?
Hepato is, I know, but hepato is liver. And something's mega, what is it? Big, yeah. So it's big liver. Hepatomegaly is large, enlarged liver. Okay. So these are the symptoms that we're going to find from this problem. So there's 2 ways to classify. The most common is the New York Heart Association heart failure classification, NYHA. It's the NYHA-CHF scale, or if you ever see the NYHA scale, this is what they're talking about. So when you enter into heart failure, we'll scale you on a scale of 1 to 4. And we will, and the higher the number, it's like a burn. The higher the number, the worse. So scale 1 is no big deal. You're in heart failure, but you're compensating. Your body's able to compensate. And that means that, yeah, you're in heart failure, your contractility might be a little bit decreased, or the filling pressures may be a little high, but does your body notice anything? No. Does it limit your activity at all? No. Stage 2 means that, hey, I'm okay most of the time. My body can compensate most of the time, but if I do some very sudden activity, like go up and down stairs very quickly or try to do a short run, my body says what? Let's just take a nap. Let's not do this again. But otherwise, my daily activities, getting dressed, going, doing small chores around the house, driving, no big deal. Stage 3, even walking can cause me some problems. So stage 3 is more limiting. I used to walk, 5 blocks. Now, walking 4 blocks kind of wears me out. Like daily, doing simple chores around the house, I can, vacuum or dust for, a little bit, and then I just get wiped, and I just can't finish it. It's a class 3. Class 4 is, I don't even want to dust. Well, not that any of us want to, but I can't even get up and vacuum. Class 4 can be to the point of, I can't even get dressed in the morning. I just want to, class 4. I feel you. I just want to sit here in my bed and it's not that I don't want to, which is my problem. It's just that I can't. It's class 4. The higher the class, the more severe you are. Okay, higher the class, the more severe you are. Stage of heart failure isn't as commonly used. I put it up here because you might hear some people say, as you go up on the stage, the more invasive we are going to be with our treatment. Okay, so stage A is, hey, you might form heart failure, but you haven't formed it yet, so we're going to take care of the problem that could cause heart failure, and you'll be fine. So let's say we found cardiac ischemia on you, but your heart's still working normal. If we let that cardiac ischemia go, what would happen? What would your heart enter into? Beyond injury, though. Once it's been injured, heart failure. Already entered into heart failure. What type of heart failure? Systolic heart failure. But if I treat the coronary artery disease now, will you enter into that heart failure? No. So that's a class A. You could go into heart failure because you have a condition or a pathology that could cause it. But if I interrupt that pathology now, will you enter into heart failure? No, that's a type A. Type B means you have disease, but you have not, and that is associated with the heart failure, but it has not yet developed the symptoms. So in other words, we see you have coronary artery disease, and we do an EKG on you, and you have signs of ischemia. You have inverted T waves. But when we ask you, are you short of breath? What's your activity like? You still say it's normal. So you have the pathology that can cause heart failure. There's evidence that your heart's being affected, but you haven't felt it yet. Does that make sense? That's where a lot of people are. You just haven't felt it yet. That's a type B. Type C is they have symptoms that are associated with it, but they're not severe. Okay? So you might be in a class 2 or 3. So we have ischemia. We see T waves inverted, so we know you have ischemia. And we ask you, how are you feeling? You're like, I'm just exhausted. I just can't feel like I'm going. I'm having difficulty breathing. I feel like I have to cough a lot more. I don't know what's going on. Well, now you've entered into heart failure and you're having symptoms, so you're now a C. And a D means that, hey, we fixed the problem, and guess what?
It's still there.
You still have heart failure. So with stage D, what that means is, stage C, if I fix the problem, what will happen to your heart failure? It'll go away. Those symptoms will go away. But with stage D, I saw you have ischemia. You might have had an infarct. I tell you, how are you feeling? Oh, I feel like I can't get enough breath. I can't breathe deep enough. I'm just exhausted. I don't know what's going on. We fix the ischemia. We fix the blocked artery. And guess what remains? The heart failure. Which is sometimes why we say after a certain period of time of an infarct, it doesn't really do us any good to go back. That's why chronic total occlusions, people are debating, does it do any good? Because if we fix chronic total occlusion, it is still possible that the reason we're doing it, which is to alleviate heart failure of the patient, may never go away. It might not do anything. That's what research is kind of suggesting, is that it might not have any long-term effect. Yeah, you've restored blood flow, but those tissues have been so damaged that you can't get it back. So that's a stage D. More often than not, you're going to hear the class system, though. More often than not, you'll read about class systems. So how do we diagnose heart failure? It's not easy. You would think, how are you feeling? I'm short of breath. Feel lightheaded. You have heart failure. No, it's not that easy. We have to go through a process. The first thing we do is you come in, you say, gosh, I have cankles. You know what cankles are, right? We've talked about that before. What's a cankle?
Your calf is.
The calf and your ankle are the exact same diameter, and you're kind of pooling over your shoes. I have cankles, I'm short of breath, I'm just exhausted all the time. So we're going to go through your clinical history. Okay. Do you have hypertension? Do you have a history of coronary artery disease? Do you have difficulty breathing at sleep? Yeah, okay. Matter of fact, apnea is considered one of the most dangerous signs of heart failure. There's a direct link between sleep apnea and sudden cardiac death. There's a direct link of that in adults. Sleep apnea and sudden cardiac death are directly linked. And we know that sleep apnea, sudden cardiac death all have a link to heart failure. So if you have that, and you're also edemic, you're going to say, let's take a look at your heart. How's your heart doing? They're going to do a physical exam. They're going to listen for your lungs, see if you're in left heart failure. If you're in left heart failure, I will hear crackles in my lungs called rales. It sounds like a percolating coffee pot. When you listen to the lungs, you hear this. I'm going to drink, my mouth is dry. you hear this bubbling sound in their lungs. That's fluid building up in the lung, in the alveolar sac. It's called rales. Sign of left heart failure. They're gonna look at the edema. Are you in right heart failure? You push on the leg. Now normally, when I push on my leg and I release it, what happens to that dent that I put in my leg? It goes away. Who's ever been pregnant and had edema? Who wants to admit it? So what happens is you push on their leg and you remove the finger, and what stays in the leg? The dent. That's called pitting edema. Very common in pregnancy, by the way. If you've had it during pregnancy, it's just the severity that we don't want. When it gets severe. But edema, that's edema. So you just have to go and push, and we're like, boop. Oh, it's not bouncing back. And you rub it. If you rub it and it still doesn't bounce back, that's a lot of, because what you're doing is when you push into the leg, you're pushing the fluid out of the tissue space, and that's why it stays there. Because it's kind of like, has anyone ever played with kinetic sand? Where you put your hand in the sand, and what happens to the sand? It just disperses, and you pick up your hand, and what's still left in the sand? Yeah. So we've dispersed all the fluid out of the way, and so we have this perfect thumbprint in your foot. Heart murmurs. Are you volume overloaded? Are your valves now regurgitating? Do you have jugular distension? Again, right heart failure. Does your heart sound physical? You feel the chest? Does your heartbeat feel kind of here? Or does it kind of displace? As your heart enlarges with heart failure, it can kind of change the position of your heart in your body. EKG. Is there anything weird with your EKG? There's 3 labs that we've talked about, or 2 labs specifically: NT-proBNP and BNP, and it's basic natriuretic peptide. BNP is basic natriuretic peptide, and NT-proBNP is non-transverse. I can't remember what I can't remember it. But proBNP is another form of the test. BNP is released by your atria when it gets stretched out. Your atrias release this chemical called BNP. And when that is elevated at a certain point, it's a sign that you're in heart failure. Your atrias are overstretched. So BNP is actually released by the atria. Okay. And then we're going to do an echo. And the echo is the determining factor. The echocardiogram is the determining factor. If you don't have symptoms, you're not going to be in heart failure. Does that make sense? Or it's not severe enough for us to go any further. If you have symptoms, but you don't have any BNP elevation, then you're probably not in heart failure or not significant enough. And then, of course, definitely, if you have an echocardiogram, if these are all true, but your echocardiogram is normal, then you're not in heart failure. Does that make sense? So we start with this. If you don't have any of these, you're not in direct heart failure right now. We're going to try to find something else, or you most likely aren't. If you have this, greater than 1 of these, you'll go here and withdraw your BNP. If your BNP is normal, we're not going to do an echo on you. We're just going to stay here and say, we're going to watch it, you're not severe enough. If this is abnormal, then we're going to do an echocardiogram. If your echocardiogram says that your ejection fraction is less than 40%, or you have diastolic failure, even with ejection fraction, if your heart isn't able to relax, it's very stiff, then you're in heart failure. So this is the process of identifying and diagnosing heart failure. Then you should have talked about this, and we'll talk about this more next week when we talk about heart failure and different cardiomyopathies. All of these are medications that you talked about in pharmacology. If you're giving these medications and if your patient is still symptomatic, then you're classified 1, 2, 3, or 4. So you're type 1, you add aldosterone, or excuse me, 2 to 4, you add aldosterone. If you're 3 and 4, you'll also add hydralazine and nitrates, like nitroglycerin. There's a new drug called idobradine. If you're class 2 or 3 and you can't do the beta blockers anymore, you can consider this. If your ejection fraction is low enough, you get an ICD. If your ejection fraction is really low and you have a long QRS complex, you get something called CRT that we'll talk about next week. So basically, when you have heart block, or when you have heart failure, you're starting with all these medications. They're just going to put you on them. If these don't work, If you're class 2 and 4, you'll get aldosterone. If you're class 3 or 4, you'll get aldosterone and hydralazine and nitrates. They'll add both of those. If your heart rate is greater than 70, they give you ivabradine, which is a suppressor to the heart rate. If your ejection fraction is low enough, you'll forget about all of this and you'll get an ICD or a CRT. And we'll talk about what cardiac resynchronization therapy is next week. Sound good? Okay, so heart failure, is it a pathology on itself?
No.
Is it a condition?
Yes.
Can we treat the condition really? Can we cure the condition? No. Matter of fact, all we can do is try to treat the symptoms. That's all we can do is try to track down the symptoms and treat the symptoms, which is what the drugs do. What type of heart failure do I have? Systolic and diastolic, which is most common? Systolic. Which one is caused by myocardial infarctions? Most commonly? Systolic. Diastolic a little bit, but mostly systolic. Which one is caused by valve disease? Systolic. Which one is caused by volume overload?
Diastolic.
Systolic. Systolic is volume overload. Kind of both, but more systolic. Diastolic is usually very, very specific. Leading cause of right heart failure?
Left heart.
Left heart failure. Leading cause of left heart failure?
Systolic.
That's the leading type. A leading cause. What is the number one cause of death in the U.S.? Coronary artery disease. Yep, so ischemia, injury, and infarct would be the leading cause of left heart failure. Okay, that is enough for heart failure. That will also be, we're going to take all that and bring that with us next week when we talk about the different cardiac pathologies, cardiomyopathies. We're going to take about a 20-minute break. When we come back at 10:30, we are going to come back to talk about our ACLS categories and finish that up. Sound good? Okay, take about a 20-minute break.